Good morning. Welcome to our participants in the room and also our web stream participants to day 2 of the NHSN training. My name is LaTasha Powell. I'm one of the BSI subject matter experts here at NHSN. Today we're going to cover secondary BSIs, a tale of two scenarios. So secondary BSI attribution is important, not just because we could potentially avoid the financial consequences associated with primary BSIs, but when secondary BSI attribution is applied correctly, we're able to make sound, informed decisions on our preventive efforts. We can all agree that this is at the very core of what we do as infection preventionists. We use the data to drive our preventive efforts and our interventions. So before we take a deep dive into secondary BSIs, I wanted to highlight a couple of misconceptions associated with secondary BSI attribution. And let's see if any of these are familiar to you. The first one is if I have a positive site-specific culture and a matching blood culture, the blood culture is automatically secondary. How many times have you heard that? All right, what about this one? Misconception 2. If a physician documents that the positive blood culture is secondary to an infection, the positive blood culture can be deemed secondary. Misconception 3. I can deem a positive blood culture secondary to a present on admission infection, even if the patient did not meet an NHSN site-specific criteria. I'm glad some people are saying no to this. And our fourth and final misconception, if I meet any NHSN site-specific infection, I can deem the positive blood culture secondary to this criterion. Glad you all are saying no. So by the end of this presentation, our hope is that participants will be able to apply foundational concepts from Chapter 2 and 4 regarding primary and secondary bloodstream infections, identify the relationship between site-specific infections and secondary bloodstream infections, utilize Appendix B, our secondary BSI guide and reference table found in Chapter 4, and apply the two scenarios for secondary BSI attribution to case studies. So to appropriately apply secondary BSI attribution, you must know where to locate your resources. On the NHSN BSI website, under the Protocol tab, you'll find two important links. In the BSI Event Protocol, or Chapter 4, there's a secondary BSI guide that starts on page 4-32. Also, under this tab, you'll find a link to Chapter 2, which provides foundational concepts for BSIs and all other site-specific infections in the Patient Safety Manual. Table B1 can be found in the BSI chapter on page 4-36. This table provides a list of the infection criteria that are eligible for secondary BSI attribution. Additionally, it divides the NHSN site-specific criteria into the two scenarios required to deem a blood culture secondary. And this actually addresses misconception 4, that if I meet any NHSN site-specific infection, I can deem the blood culture secondary to this criterion. So I'm a visual learner, and so if you are a visual learner like I am, you'll find this document useful. This algorithm actually will walk you through the steps for ruling out a primary BSI. And this document can be found on page 4-44 of the BSI chapter. Under the Supporting Material tab, you will find another helpful resource. It is the link to the CDC NHSN surveillance definitions for specific types of infection. These are your Chapter 17 definitions. This is where you will find your definitions for intra-abdominal infection, sinus infection, your necrotizing enterocolitis, and your bone infections. But please note that the pneumonia, VAE, and SSI and UTI chapters are also available for secondary BSI attribution where applicable. All of our infection criteria have been formatted into checklists. These documents were adapted from the Tennessee HAI checklist and are available as a resource. So you can print them out and you can check off how or if an infection criteria is met as you're doing your chart reviews. So when you click on the checklist link like this one for bone, this is the document that you will see. And actually, during our group exercise later today, you will be using some of these checklists. So let's look at primary BSIs versus secondary BSIs. So what is the difference? Well, I'm so glad you asked. A primary BSI is a laboratory confirmed bloodstream infection where an eligible BSI is identified and the BSI is not secondary to an infection at another body site. In other words, it is an LCBI1 or an MBI LCBI1, an LCBI2 or an MBI LCBI2, an LCBI3 or an MBI LCBI3. These events are reportable to NHSN if the eligible central line is in place and it is part of your location's monthly reporting plan. An eligible central line is a central line that has been in place for more than 2 consecutive calendar days following the first access of the central line in an inpatient unit during the current admission. Secondary BSIs, on the other hand, are associated with a site-specific infection at another body site, which may have seeded the bloodstream. For example, you may have an IAB1 criteria 1 with a secondary BSI, or you may have a pneumonia with a secondary BSI, or a GIT2C with a secondary BSI. These events are not reportable to NHSN as an LCBI event. So again, it's the visual learner in me that kind of creates graphs and stuff to help put things in perspective, but this diagram really helps me put the primary and secondary BSI definitions into perspective. The primary BSI is basically standalone. It does not occur as a result of another site-specific source. The secondary BSI, on the other hand, occurs as a result of a source at another site. So, for example, you can have a secondary BSI because you have a pneumonia or a urinary tract infection, or maybe even an SSI or an eligible infection criteria from Chapter 17, or even a VAE. So we're going to have our first knowledge check just to make sure that you all are still with me before lunch. So it is primary BSIs are reportable to NHSN if an eligible central line was in place and part of your monthly reporting plan. So you would type A for true and B for false. And you can make your selections now. Okay, I'm going to give a few more seconds for our web stream participants. Okay. So 99% of you are correct. That is true. So let's look at the rationale here. So a primary BSI is reportable to NHSN if an eligible central line is in place and part of your location's monthly reporting plan. So on to important key terms. So my colleague Dominique Johnson covered this information in her presentation, but I wanted to do a quick review of some of these BSI key terms because they're very important to the application of secondary BSI attribution. An infection window period, or an IWP, is a 7-day period in which all site-specific infection criteria must be met. It includes the collection day of the first positive diagnostic test that is used as an element to meet the site-specific infection criteria, the 3 calendar days before, and the 3 calendar days after. The repeat infection time frame is a 14-day period in which no new infections of the same type are reported. The secondary bloodstream infection attribution period, or SBAP, is the period in which a blood specimen must be collected for a secondary BSI to be attributed to a primary site of infection. It includes the infection window period combined with the repeat infection time frame and can be 14 to 17 days in length depending on the date of event. So this is just an example. We have a patient who was admitted on 1/6, and on 1/11 they have an IR drainage of an intra-abdominal abscess that is positive for enterococcus, and it meets IAB1 on 1/11. The IAB IWP is 1/8 to 1/14. The RIT is 1/11 to 1/24. And the IAB SBAP is 1/8 to 1/24, because remember, the IWP and the RIT are combined. Well, our endo criteria is a little different. So the endo infection window period is 21 days during which all site-specific infection criteria must be met. It includes the date of the first positive diagnostic test that's used as an element to cite an endo, the 10 calendar days before, and the 10 calendar days after. The endo RIT, let me just go back to the endo infection window period. The reason why this infection window period was actually extended is because it does take an extended amount of time to make a clinical determination for an endo. I can tell you in my personal experience as an IP, I can't tell you the number of times I have waited for that TEE just so that I could see if that blood culture was secondary. And I waited, and I waited, and I waited. So this gives you that 21-day period so that you can wait it out a little bit to see if that blood culture is secondary. And of course, you have to keep in mind that all of the elements must be present within that 21-day time frame. So the endo RIT is extended to include the remainder of the patient's current admission, and the SBAP includes the 21-day infection window period and all subsequent days of the patient's current admission. However, it is limited to the organisms identified in the blood specimen that match the organisms used to meet the endo definition. So let's say, for example, you have a patient who initially had Staph aureus blood cultures that were positive that you were able to deem the endo criteria secondary to. But then later in that mission, that patient has an E. coli blood culture. So it's at that point, then you need to try to assess that particular blood culture for an LCBI. It could be secondary to the endo, but you do need to do your due diligence and do your workup to determine if it's secondary to an endo or secondary to another site-specific source, or whether it meets LCBI criteria. So let's move on to some secondary BSI concepts. So scenario 1, to apply scenario 1, you must have at least one organism from the blood specimen that matches an organism identified from the site-specific specimen that is used as an element to meet the NHSN site-specific infection criteria. And the blood specimen is collected during the secondary BSI attribution period, or SBAP. To apply scenario 2, you must have an organism identified in the blood specimen and it's used as an element to meet an NHSN site-specific criterion and is collected during the site-specific IWP. You'll notice here that I have highlighted the time frame during which a blood culture must be collected for each of the scenarios. So for scenario 1, the blood culture must be collected during the secondary BSI attribution period. For scenario 2, the blood culture must be collected during the site-specific IWP. And this actually addresses misconception 1, that if you have a matching blood culture and a site-specific specimen, you can automatically deem a blood culture secondary. Because what you will find is that the matching blood culture and the matching site-specific is not all that you will need to apply secondary BSI attribution. There is one exception, to both scenario 1 and scenario 2, and that is our necrotizing enterocolitis definition, or NEC. And you'll notice that in this definition, there's neither a site-specific specimen or blood culture that is needed to cite a NEC definition. However, a BSI is considered secondary to NEC if the patient meets one of the two NEC criteria and an organism identified from the blood specimens collected during the secondary BSI attribution period, and it is an LCBI pathogen, or the same common commensal is identified from two or more blood specimens drawn on separate occasions or collected on the same or consecutive days. And this statement can be found in Chapter 4, page 4-32. Positive blood culture on admission does not necessarily set a BSI RIT. For example, a patient is admitted on 112 and has a positive blood culture for E. coli. And then on 121, there's a positive blood culture for Staph aureus. Please note that only primary BSI set a 14-day BSI RIT. Secondary BSIs do not have an RIT. The RIT will be set for the primary type of infection. So this is a really important point that I wanted to highlight for everyone. So usually when you get a blood culture that's collected on admission, what is the first thing that you do? You would look at it to determine if perhaps it's attributed to the previous admission or a previous facility, right? Or facility, right? But then what do you do after that? Toss it, right? Out of sight, out of mind, right? At least that was what I would do. So you would either toss it into the confidentiality bin that you have at work, or you would hit non-relevant on the artificial surveillance system that you have. However, if you have a subsequent blood culture that's positive, you have to go back to that POA blood culture, and determine if that blood culture was truly primary or secondary. Does that make sense? Okay. And so this information can actually be found in Chapter 4 on page 4-14. So this is an example to explain that scenario. So we have a 55-year-old patient who was admitted with fever of unknown origin. So they do a workup, and they collect a UA and a urine culture and also blood cultures. So the urine culture comes back positive for greater than 10 to the 5th colony forming units of E. coli, and also one of the two positive blood cultures are positive for E. coli as well. However, we have this blood culture on 121 later in the admission that is positive for Staph aureus. Now, this this example will address misconception 3, that I can deem a positive blood culture secondary to a present on admission infection, even if the patient did not meet an NHSN criteria. And we will further explain this on the next slide. So initially, after we've determined if that blood culture was attributed to another admission or another location, another facility, we would have disregarded it. But now that we have that subsequent blood culture on 121, we have to go back and determine if that blood culture on admission is truly primary or secondary. So when we review the POA blood culture, it's determined that a POA SUDI1B is fully met on 112, and that the E. coli blood culture, because it matches the site-specific specimen, the organism in the site-specific specimen, and is collected during the 110 to 125 SBAP, it is deemed secondary. However, the Staph aureus blood culture does not match the organism in the urine culture used to cite the SUDI1B, and therefore cannot be deemed secondary to that SUDI1B event. The Staph aureus blood culture would meet HAI LCBI1. So I want to ask you a question here. So what would have happened if we had assumed that POA blood culture was an LCBI1? We would have captured that second blood culture in the RIT, and that would have been an incorrect determination. So if we had been surveyed, then we would have a lot of explaining to do, would we not? Okay, so there are some consequences associated with ensuring that we're making the correct determination. So, as always, our story begins with a positive blood culture, doesn't it? And so, a lot of questions start to go through our minds, right? Start to wonder if we have any matching site specific specimens. Do we have any sputum that matches? Do we have any urine cultures that match? Do we have any peritoneal fluids or pericardial fluids that match the blood culture? We wonder if we have any imaging tests available that would potentially indicate that there's another site-specific source. We wonder if the patient perhaps had a recent surgery and we can attribute that SSI, that blood culture, to an SSI. We wonder if we had a central line, and probably should have been the first one, right? Yeah. We wonder if the patient has any localized symptoms, any redness, pain, heat, anything that might indicate that there's some localized symptoms of infection. And then we wonder if there's any evidence of gross anatomic evidence. So did they have some type of abscess that was collected and there was purulent drainage collected that we could potentially attribute that blood culture to? So now we're going to take an even deeper dive into the two scenarios for secondary BSI attribution. And we'll start with scenario 1. So this section will include not just case examples, but helpful concepts for the application of this scenario. And I know I'm between you guys and lunch, so I'm going to try to stay on time. So for scenario 1, at least one organism from the blood specimen matches an organism identified from the site-specific specimen that is used as an element to meet the NHSN site-specific infection criterion, and the blood specimen is collected during the secondary BSI attribution period. So that was a lot to say in one breath. However, this is a pretty long statement, but there are 3 key statements that you can pull out of this one long one that will give you the criteria for applying secondary BSI. And that is, the blood in the site-specific specimen has at least one matching organism. The site-specific specimen is used as an element to meet a primary infection criteria, and the positive blood culture specimen was collected during the SBAP of the site-specific infection. So I like to ask questions. And so there's some questions that you might want to ask when applying scenario 1. So the first question you want to ask is, does at least one organism in the blood culture match the organism in the site-specific specimen? Can the site-specific specimen be used to meet a site-specific criteria? And the final question is, was the blood culture collected during the SBAP? If the answer to all 3 of these questions is yes, then scenario 1 can be applied. So we have a new matching organisms table that was added to the 2019 protocol. It can be found in chapter 17 on page 17-3. It provides examples for determining whether or not you have matching specimens. So whether you have a site-specific specimen and a blood culture, or you have 2 blood cultures, you can use this as a guide to determine if you have matching organisms. So we know that, for example, Enterobacter orogenies and E. cloacae are not matching. However, if you do have a site-specific specimen for yeast and a blood culture that is positive for Candida, they are considered matching organisms. If the organism identified in the site-specific specimen is excluded and cannot be used to cite a site-specific infection, the blood culture cannot be deemed secondary to the site-specific infection criteria. So, for example, let's say if you have yeast in a urine culture, but we know that yeast is an excluded organism for UTI. So if it's an excluded organism for UTI, then we can't use that specimen to cite a UTI and deem the blood culture secondary to that. Does that make sense? Okay. I hope you guys are just telling me yes because you understand and not because I'm between you and lunch. All right, so let's talk about scooping organisms or orphans. It's very important that you pay close attention to your blood cultures. If a single blood culture contains an organism that matches the site-specific specimen and an organism that does not match, you can scoop up the orphan or non-matching organism. The non-matching organism is only scooped up when there's a matching organism in the same blood specimen. Does that make sense to everybody? Okay. If there are subsequent blood cultures with only the non-matching or orphaned organism, you must assess the blood cultures for LCBI criteria. So let's look at an example. So in this example, we have a 44-year-old patient who's admitted on 2/8. The patient had a fever on 2/9 and 2/10. And on 2/11, there's a urine culture with 100 K of Acinetobacter baumannii. No Foley was placed during the admission. The patient met criteria for a SUDI 1B on 2/9. On 2/14, the blood culture is positive for Acinetobacter baumannii and also Enterobacter cloacae. Because this blood culture contains at least one organism to match the urine culture, both organisms are deemed secondary to the SUDI 1B. Does that make sense to everyone? Okay. I guess it would have helped if I had done a little bit of the animation there, but okay. So let's look at a case example to apply scenario 1 for secondary BSI attribution. We have on 325, we have a 25-year-old female with a history of lupus who's admitted to a telemetry unit. On 330, a pericardial fluid was collected and cultured Streptococcus pneumoniae. The following day, on 331, a blood culture is positive for Streptococcus pneumoniae. So remember the three must-haves to apply scenario 1. The blood specimen and the site-specific specimen must contain at least one matching organism. The site-specific specimen is used as an element to cite a primary infection criteria, and that the positive blood culture is collected during the SBAP and the SBAP of the site-specific infection. So let's look at this example in table form to determine if we have the three must-haves for scenario 1. So the 331 blood and the 330 site-specific specimen both have matching organisms. Additionally, the pericardial fluid or the site-specific specimen was used to cite a card 1 on 330. And the blood culture that was collected on 331 was collected during the 327 to 412 SBAP of the card 1. So we would consider the Streptococcus blood culture secondary to card 1. So let's look at another example. So on 9/12, we have a 40-year-old with a history of diabetes and IV heroin abuse, and he's admitted to a medical unit. He has a PIC placed on admission. On 9/14, he's reported pain in his left forearm. On 9/15, he has a fever and a superficial draining wound that is cultured. Please note that this is not an IV site, and blood cultures were collected as well. So the skin culture comes back positive for MRSA, and there's also an MRSA positive blood culture on 9/15. And erythema was documented on 9/18. And of course, we know that doesn't mean that it was not necessarily there before, but that was when it was documented. So what determination should be made in this case? And this is actually your opportunity to make a determination. So I've provided the skin criteria here for you all to review. Is it A, 9/15 skin 1 with a secondary BSI, B, a 9/15 LCBI 1, C, a 9/14 skin 2A and a CLABSI, or D, a 9/14 skin 2A and a secondary BSI? And you can make your determinations at this time. I'm going to give a few more seconds as well for hear some discussion in the room, and then also for web stream participants. Okay, has everyone made their determination? So the answer is actually D, skin 2A with a secondary BSI, and let's talk about the rationale. So skin 2A was met on 9/14. On 9/15, you have an eligible specimen that was collected for MRSA, that tested positive for MRSA, and that eligible specimen created an IWP of 9/12 to 9/18. During that IWP, you'll find that on 9/14, pain and the erythema on 9/18 were captured in the IWP. Because pain is the first element identified in the IWP to cite the skin, the date of event is 9/14. The repeat infection time frame is 9/14 to 9/27, and the SBAP is 9/12 to 9/27. Because the MRSA blood culture matches the site-specific specimen, and that site-specific specimen was used as an element to cite a skin, and the blood culture is collected during the SBAP, it is considered secondary. Let's move on to another example. So we have an individual who on 9/14 is a 50-year-old patient admitted to the medical ICU with a blood glucose of 900. A past medical history of diabetes, hypertension, and diverticulosis, and the patient had a PIC placed on that date. On 9/18, the patient had a CT scan that revealed intra-abdominal abscess. The blood cultures are negative, and then the patient had an IR drainage of 200 cc's of purulent drainage, and the culture was positive for E. cloacae. On 9/28, the patient had a blood culture that was positive for Enterococcus faecalis, and it's vancomycin resistant. So what is your determination in this case? Is it A, 9/18 HAI IAB1 with a secondary BSI, B, a 9/28 CLABSI, and C, a 9/18 HAI IAB1 and a 9/28 CLABSI, or D, a 9/18 IAB2B? Okay. All right, so the answer is an HAI IAB1 and a 9/28 CLABSI. Now let's look at the rationale. So an HAI IAB1 was met on 9/18 with the positive abscess culture for E. cloacae. The IAB IWP is 9/15 to 9/21. Because the abscess culture is the only element required for IAB1, that is also the date of event. The HAI IAB RIT is 9/18 to 10/1, and the SBAP is 9/15 to 10/1. Additionally, you have a VRE positive blood culture that does not match the organism in the abscess culture. Because no other site-specific source can be identified, it meets for an HAI LCBI1 and a CLABSI because an eligible central line was in place on the date of event. So now we're going to move on to scenario 2. To apply scenario 2, you must have an organism that is identified in the blood specimen. It's used as an element to meet an NHSN site-specific infection criteria, and therefore it is collected during the site-specific infection window period. So out of this sentence, you have 2 must-haves to apply scenario 2. You have a positive blood specimen that's used as an element to meet a primary site-specific infection criteria, and you have a blood specimen that is collected during the IWP or the surveillance period if it is an SSI. So again, there are some questions that you should ask when applying scenario 1. The first one is, can I use the blood as an element to cite an infection criteria? And the second question is, was the blood collected during the IWP? If the answer to the 2 questions is yes, scenario 2 can be applied. So let's look at a scenario or a case example. On 122, we have a 60-year-old male admitted with a right lower leg wound. On 124, right lower leg pain is documented in the nurse's notes. On 126, they have a 102 degrees Fahrenheit fever. On 127, they have Staph aureus blood cultures ×2 and vancomycin is initiated. On 128, there's an MRI with findings compatible with diffuse tibial osteomyelitis. So let's look at this case to see if we can apply scenario 2, the 2 must-haves. To meet bone 3A, you must have 2 localized symptoms, a positive blood culture, and an imaging test that is suggestive of infection. So, when we look at the 2 must-haves to apply scenario 2, the 127 blood culture is used as an element to meet bone 3A. 2, the blood specimen was collected in the IWP, and in this case, it is the first diagnostic test used to cite the bone criteria. The bone specimen creates a 124 to 130 IWP. The 124 pain and the 128 MRI that is suggestive of infection are captured in the IWP along with the fever. Because the blood culture is used as an element to cite bone 3A, and the blood culture was collected during the 124 to 130 IWP, the positive blood culture is deemed secondary. So now we have a case example for you all to make your determination. On 4-1, we have a 70-year-old man who was admitted to the burn unit with a 2nd-degree burn to his right chest. On 4-3, you have a pick placed. On 4-8, the only nurse's note that documents the wound indicates new purple-colored SR noted on the right chest wound. On 4-12, there's a fever and blood cultures are collected. The blood culture is positive for Staph aureus and vanc is started. On 4-20, the right chest wound is healing and the patient is discharged. So what determination should be made in this case? A, no infection identified. B, a 4-8 burn 1 with a secondary BSI. C, 412 LCBI 1. Or D, a 412 CLABSI. Okay, gonna give it a few more seconds. Okay, so the correct answer is actually D, a 412 collapsy. So I hear some rumblings in the room, so let's go over the rationale, okay? So based on what is provided, the patient had two elements that are eligible to meet burn 1. However, the documentation of the SR falls outside of the 4.9 to 4.15 IWP set by the blood culture. So an LCBI-1 is cited on 412. Additionally, because a PIC was accessed on an inpatient unit greater than 2 consecutive calendar days on the date of event, it is a collapsy event. So the correct answer is D. Okay, so we have another scenario so that you all can make a determination. On 6-3, we have a 45-year-old who was admitted with diabetes, a gangrenous foot, and an inflammatory bowel disease. On 6-4, an AMP was performed. 6-12, they have a fever and blood cultures are collected, and one blood culture comes back positive for Clostridium species. On 6-13, the CT scan reveals right lower quadrant abscess. And on 6-15, there's documentation of hypotension. Please note that there were no signs or symptoms of a surgical site infection. So the question is the Clostridium blood culture secondary to IAB? Vote A for yes and B for no. Okay, going to give you a few more seconds. Looks like you all are pretty split here. Okay, so let's look at the answer, the correct answer. The correct answer is actually yes. The Clostridium species blood culture can be deemed secondary to the IAB. So let's look at the rationale. So an IAB 3B was met on 6-12. The Clostridium blood culture is an eligible specimen for IAB, and it sets the 6-9 to 6-15 IAB IWP. The 6-12 fever and 6-13 imaging suggestive of infection along with the 6-15 hypertension are all captured in the IWP. So again, the date of event was 6-12. The RIT is 6-12 to 6-25, and the SBAP is 6-9 to 6-25. It is possible to attribute a blood culture to more than one site-specific infection. In this scenario, we have a patient under the age of 65 who met a SUDI 1B criteria on hospital day 4. During the hospital day 1 through day 17 SBAP, a matching Klebsiella pneumoniae blood culture is collected and deemed secondary to the SUDI 1B. Additionally, the same Klebsiella blood culture is used as an element to cite an IAB 3B, with the imaging test suggestive of infection creating the IWP, and the fever, abdominal pain, and the blood culture are captured to cite an IAB 3B. Because the Klebsiella blood culture is used as an element to cite the IAB criteria, it is deemed secondary. And this example can be found on page 4-4-40. It is also possible to remeet an NHSN site-specific infection to capture a non-matching organism. So we're going to use the same IAB1 example that we have used previously, and an IAB1 is cited on 9-18. However, during the RIT of the IAB1, a non-matching Enterococcus faecalis blood culture is collected. This non-matching blood culture is used to remate an IAB criteria, specifically IAB 3B. Because the IAB 3B was met using the E. faecalis blood culture during the initial IAB RIT, this blood culture is deemed secondary to IAB as well, and the organism is added to the event. And I'm sorry, I didn't do my animations here. My apologies. So, about VASC, we've received several questions from users regarding the VASC criteria and secondary BSI attribution. Please note that a blood culture can only be secondary to an organ-space SSI VASC, as seen here in Table B1. And that Table B1 again can be found on Chapter 4, page 4-36. So now we're going to move on to some case studies. So you guys have some practice before the group exercise. So case study 1. On 9/12, a 25-year-old is admitted with severe right jaw pain due to a tooth abscess. Patient had documented fever of 102 degrees Fahrenheit. The patient attempted to treat his abscess at home with antibiotics left over from a sinus infection, which is an absolute no-no, right? Patient had negative blood cultures on admission and had poor venous access, so a PIC was placed on admission. The patient had unbearable pain and also a fever on 9/13. There was purulent drainage noted in the right posterior oral cavity, and it was cultured. The culture came back positive for Prevotella and Streptococcus viridans. On 9/16, there's a blood culture collected for MRSA ×2. So the question is, can the 9/16 MRSA blood culture be deemed secondary? A for yes and B for no. Okay, gonna give a couple of more seconds for our web stream participants. Okay, so the correct answer is actually no, which is great. 91% of you all agreed. So let's look at the rationale. So on 9/13, an oral 1 is cited using the eligible oral cavity culture that was positive for Prevotella and Streptococcus viridans. Although this is the only element used to cite an oral 1, it does create a 9/10 to 9/16 oral 1 IWP, and then also an oral 1 9/13 to 9/26 oral 1 RIT, and an SBAP of 9/10 to 9/26. Because the blood culture does not match the organism identified in the oral culture, the MRSA blood culture cannot be deemed secondary to the oral. Because an eligible central line was in place, a CLABSI event is cited on 9/16. Good job, guys. Next question. On April 1st, the patient is admitted with fever and abdominal pain. On April 2nd, a PIC line is placed. On 9/14, you have an ultrasound-guided drainage of 4 liters of purulent peritoneal fluid that is positive for Enterobacter cloacae and Proteus mirabilis. On April 10th, there's abdominal pain that the patient reports to be increased. On 4/11, the patient has a CT scan with multiple liver abscesses. The blood cultures are positive ×2 for Candida albicans and Morganella species. On April 13th, there's jaundice and fever. So the question is, should the determination be made? What determination should be made in this case? A, eclampsy, B, an SSI IAB1 with a secondary BSI, or C, an IAB with a secondary BSI. Going to give a couple of more seconds for our web stream participants. Okay, so the correct answer is an IAB with a secondary BSI. So let's look at the rationale. So the answer is, so I gave the answer, it's a IAB with a secondary BSI. So an IAB1 is cited on 4.4 with the positive purulent blood, peritoneal blood culture peritoneal culture, with an E. cloacae and Proteus mirabilis. That is the only element that is used to cite an IAB1. So that is the date of event 4.4. It still creates an IWP of 4.1 to 4.7. And additionally, it creates an RIT of 4.4 to 4.17. But you'll notice that on 4.11 that there is a blood culture that for Candida albicans and Morganella species that does not match the site-specific specimen or the peritoneal fluid. So you must remeet or use that blood culture to either determine if it's an LCBI or remeet again. So in this case, we were able to remeet IAB during the initial RIT with an IAB 3B. So because the blood culture is used as an element to meet IAB 3B, it is deemed secondary. But please note that only the 4.4 IAB1 would be reported, and the Candida and Morganella are added to the original event. This is an example of remeeting an infection criteria to capture non-matching organisms. So case study 3. On July 4th, we have a 30-year-old patient admitted with ulcerative colitis, and he reports severe abdominal pain, and he has a past medical history of heroin IV drug abuse. On July 5th, they have a PIC placed after his peripheral was dislodged. On July 9th, the patient has nausea, vomiting, and increased abdominal pain. On 6/10, the patient has fever, continued abdominal pain, and a CT scan that reveals dilatation pronounced in the transverse colon. Blood cultures are collected on July 10th that are positive for Pseudomonas ×2. On July 12th, you gotta love this, the MD notes that the Pseudomonas blood culture is secondary to a colonic source. So what determination should be made in this case? And I've provided 2 of the infection criteria for you to review, and it should be in your handouts, and I'll ask that you make a determination. So A is a 7/9 intra-abdominal infection with a secondary BSI, a 7/9 GIT with a secondary BSI, C, a 7/10 CLAPSY, or D, a 7/10 OREP with a secondary BSI. Okay, so the correct answer is actually C, 710 CLABSI. So let's look at the rationale here. So in this case, IEB, GIT, and OREP cannot be met. The patient had 3 eligible symptoms on 7-9, 7, and 7-10. However, only 2 of those symptoms would have been required had they had cited an IEB or a GIT. The imaging finding is not suggestive of infection, nor is it equivocal. And the physician's documentation cannot be used as an element to apply secondary BSI attribution. Because a site-specific source cannot be identified, a CLABSI is cited on 710. This addresses misconception 2, that a physician's documentation of a secondary source can be used to determine secondary BSI attribution. So this is some helpful information just for you all to have. So when submitting a case to NHSN, we would like to have the following so that we can make a very clear, concise determination for you. We want to have an idea of what type of site-specific infection you're thinking about attributing the blood culture to. And we need supporting documentation. So if there's any positive blood cultures or imaging or signs or symptoms, please send this information with the associated dates. We also would need the dates and results of the positive blood cultures, and it's very important that you include all of the organisms that are identified in each blood specimen, because we want to try to see if we could perhaps scoop any of those organisms in and deem them also secondary. So I know sometimes it may be a little frustrating that we would ask you those type of questions, but we're really trying to help to make sure that we're giving you a clear determination. And then any information on a recent NHSN surgical procedure would also be helpful, because the rules for secondary BSI attribution are actually different for SSIs. So it's very important that we have that information so that we can kind of give that information to our SSI experts so that they can review the case. So in summary, there are 2 ways to make a secondary BSI determination. Scenario 1, where the organism and the site-specific specimen is used to meet the criteria and the blood is collected during the secondary BSI attribution period and matches at least one site-specific specimen. Or scenario 2, the organism is identified in the blood specimen is used as an element to meet the site-specific infection criteria and therefore must be collected in the IWP. If neither scenario is met, the BSI is a primary infection. The only exception to this rule is the NET criteria. POA BSIs must be investigated when a subsequent blood culture is identified within 14 days. Otherwise, an incorrect determination can be made. So only a primary BSI will create a 14-day BSI RIT. Blood specimens occurring in the SBAT must contain at least one matching organism to the site-specific specimen that was used to meet the definition initially. Otherwise, it must be investigated as a primary or secondary source. Sometimes a patient may meet more than one criteria for a type of infection. If this occurs, consider all potential IWPs to identify possible primary sites of BSIs. There are some training videos and quick reference tools that I did not mention in my presentation, and also a worksheet generator, the HAI checklist. There are available resources for you all so that you all are equipped with the information to perform surveillance in your hospitals. These are my resources that I used for my presentation today. I have questions, and then as always, if you ever have a question regarding a specific case, we'll be happy to review that case with you via email, or even if you need us to talk to you on the phone, we'll be happy to do that as well. So with that, this completes my presentation. Do we have any questions? Hi.
3.
Yes.
So I know there's that physician documentation of colonic infection.
Mm-hmm.
Would you not encourage us to then look for antibiotics, possibly for intra-abdominal or GIT, to see if there's documentation?
Okay, so that is a good question. So what you're referring to is clinical correlation.
Yes, for the
And
equivocal imaging.
and so this actual imaging is neither suggestive of infection or equivocal.
So
Okay?
the dilation portion of it, I know like biliary ductal dilation will
Right.
be equivocal.
Yes, but
So,
that's equivocal for cholangitis. So you would look
okay,
for clinical correlation for cholangitis. But in this case, we're talking about dilatation of the actual
colon
colon.
itself.
So
Okay.
that would not be suggestive of infection or equivocal. So in this case, you would not need to look for clinical correlation.
Okay, so equivocal imaging then for colon would include what type of phrases?
Well, it depends. It could be something that is questionable, like they will say questionable infectious source, or they could
Okay.
say questionable abscess or something like that. In that particular
Okay.
situation, then you would need documentation of clinical correlation that says, I am prescribing this antibiotic specifically for this colon infection or before this abscess. Does that make sense?
It does. So any dilation then, if it's not in the setting of like biliary ductal dilation, would not be equivocal imaging for any other
That would be correct.
site. So dilation in general. Okay,
That
thank
would be
you.
correct. Yes.
Hello, thank you.
Oh,
Clarification on the scooping orphans piece. You gave the example of the SUDI with the Acinetobacter followed by a blood culture positive for Acinetobacter and I believe Enterococcus or Norobacter or something.
yes.
And so the Enterobacter, because it was within the same blood culture, was included. If a day or two later there was an Enterobacter alone, a new blood with an Enterobacter alone, that can no longer be included because it was not
That is-
within the same blood.
That is correct.
Correct.
You would
Okay.
have to assess that blood culture for an LCBI.
Right, that's what I assume. Thank you.
Yeah. Any other questions?
There's a couple from online.
Okay.
And several of them do go back to the orphan.
Okay.
So this one, please clarify the rationale as to why the non-matching organism are allowed to be counted as secondary. I understand how to get that attribution, but I do not understand the rationale as to why this makes sense.
Okay, so to apply scenario one, the blood specimen must contain at least one organism. Okay, that is matching. So if there's another non-matching organism in that blood culture, then you can scoop up that non-matching organism in that one single blood culture only.
Okay, on case study number 1, a patient was admitted with severe right jaw pain. Why does the patient not meet oral cavity 2, has an abscess or other evidence of oral infection found on an invasive procedure gross anatomical exam? On 913, the patient had purulent drainage noted in the right posterior oral cavity. Could you explain?
Well, it actually would probably meet oral 2 as well, but I only used one category, so that the participant is actually correct. If it is gross anatomic evidence of infection noted in the oral cavity, and that is oral 2, then it would be, you could also cite that as well. And in some cases, it is possible to cite more than one, but I actually don't have the oral criteria with me, so I can't verify if that's true, but it is possible in a lot of cases to cite more than one infection. What we recommend is that you use the one with the earliest date of event.
If a patient has a recurrent BSI with a PIC in place, but also has a long-term osteo that is being treated for greater than 6 months, does the diagnostic imaging to correlate have to be within the RIT or IWP?
I would say yes if they're applying scenario one, where the blood culture would have to be collected during the secondary BSI attribution period. However, if they're using the blood as an element, that imaging must be captured in the IWP as well.
One more. If using IAB criteria to meet a secondary BSI and a blood culture has an MBI as well as a non-MBI organism, can you orphan in the MBI organism?
I don't have the criteria in front of me, but I believe that it's only one, it has to be only MBI organisms. Is that correct? I'm polling my friends here. Oh, okay, you can. Oh, I'm sorry. I stand corrected. You actually can scoop up that non-MBI organism with that particular blood culture. Okay, if you have any questions that you'd like to ask me in person, I will be available after the presentation. Thank you so much, and you guys continue to have a good day.